This is the start of our session on identifying the patient with sepsis. This is a new modality for us. This video cast will be one of several to do with the management of the patient with sepsis, and we hope that they'll also be useful in audio-only format. But this is about identification. It's about screening for the patient with sepsis and what to do when we have screened and when we've identified sepsis. My name is Ron Daniels. I'm colloquially an intensivist, so I'm a consultant in intensive care with a background in anaesthesia, and I work in Birmingham at the Heart of England NHS Foundation Trust.
And my name's Tim Nutbeam. I'm a consultant in emergency medicine and I work at Derriford Hospital, which is in the southwest.
What we're going to cover, we're going to introduce our new sepsis screening and action tool. We're going to show you an example, and this is one of a number of compatible and complementary screening and action tools that we're going to be introducing across various aspects of healthcare over the next few months.
This example is the Emergency Department Sepsis Screening and Action Tool. And as Ron said, these tools are going to be available for many or even a majority of clinical areas. There is one for the pre-hospital environment, there is one for paramedics, there is one for general practitioners, there's one for general wards, there's one for acute medical units. So there'll be a tool which is specific for your area. We've used the emergency department as an example, but there is a lot to learn from this videocast if you're using the tool in any of those other clinical areas.
So in some patients, we don't need tools like this. Some patients are obviously sick. If this patient presented to your emergency department or to your general ward or to your care home, for example, you would immediately recognise that this patient was sick. This patient clearly has a purpuric rash. Similar patients may have profoundly low blood pressures. They may be unconscious. These patients we can all identify as sick. But it's not these patients that we're missing with sepsis. Most healthcare professionals will recognise that a patient like this needs urgent attention, and hopefully sepsis will be in their list of differential diagnoses. It's the more subtle patients. Sepsis can arise from any one of a number of sources of infection, the most common being pneumonia, but also commonly abdominal infections, urinary infections. It can affect the very young and the very old, and it can come on slowly, insidiously, and it's these patients that we need to learn to spot. We need to develop a culture of awareness so that healthcare professionals have an index of suspicion of sepsis whenever a patient doesn't look quite right.
Okay, so now moving on to the tool itself, and we'll start right at the top. And the first sentence we've got is sepsis is a time-critical condition. Screening, early intervention and immediate treatment saves lives. And then it tells you which and who this tool should be applied to. And this is going to be different depending on which tool you're using. This tool, the emergency department tool, is only to be used for adult patients and patients who are not pregnant. The reason that is that patients who are pregnant or paediatric patients have different physiological variables and will respond differently to infection. This tool should also be used for patients who have a suspected infection or patients whose clinical observations, so perhaps their heart rate or their blood pressure, isn't quite within normal limits. Sometimes a patient will look just not quite right, and we want you to apply the tool to those patients too. Whilst you're listening to the rest of this videocast, try to have a think about which patients you're going to apply this tool to and what opportunities in your clinical environment you have to apply this tool. That might be during an OBS round on the general ward. It might be at majors triage in the emergency department. The times and opportunities you have to apply this tool will be completely dependent upon your working environment.
So I think we should also just say at this point, Tim, that we're not ignoring children, we're not ignoring the pregnant patient, but toolkits for the pregnant patient and for children are not going to form part of the first tranche of these videocasts and audiocasts. In the meantime, while we're developing these toolkits, we'd suggest that you approach the NICE guidelines for feverish children and the Royal College of Obstetrician and Gynecologists Green Top guidelines for sepsis in pregnancy and sepsis in the puerperium. Moving on. So these are the SIS Criteria. This is the first clinical box within the screening and action tool. SIRS stands for Systemic Inflammatory Response Syndrome, and that's what sepsis is. Sepsis is the body's response to an infection that's mediated largely by the immune system. Now, some of you may be thinking there are only 4 SIRS criteria, but that's now a bit outdated. It's true that in 1991, when the term SIRS was first coined, there were 4 SIRS criteria. But the same people who developed the concept of SIRS got together 10 years later and developed a whole new list of criteria that they termed signs and symptoms of infection. We now don't use that term. That list was about 30 criteria, and that's clearly unmanageable. So the Surviving Sepsis campaign narrowed it down to the 6 that they felt were most specific to sepsis. We see 5 of those here. The 6th is white cell count, and a white cell count of less than 4 or more than 12 is one of the SIRS criteria. The reason it's not here is that this particular tool is the emergency department tool. And when people present to the emergency department at triage, we don't have the luxury of being able to look back on an electronic system to see the white cell count from that morning or from the previous day. We do need to remember to take the white count, but at presentation to the emergency department, we're going to be limited to these SIRS criteria.
So what are these criteria? Well, at the top there, we've got temperature. People know and people readily look out for hyperpyrexia, so a high temperature. And for the purpose of SIRS, the cutoff is 38.3 degrees centigrade. People commonly miss that sepsis can present with a lower temperature, and the cutoff is less than 36 degrees centigrade. So remember, you need to look for people with both the high temperature and with the low temperature. Moving on, next SIRS criteria is respiratory rate, and the cutoff for the SIRS criteria is a respiratory rate of more than 20 breaths per minute. Now we know that respiratory rate is notoriously badly recorded, but also that when people observe people's respiratory rate, they don't always calculate it correctly. So it's one which requires a lot of attention. The third SIRS criteria is heart rate, and we use a cutoff there of more than 90 beats per minute. The fourth SIRS criteria is acute confusion or reduced conscious level. It's important to remember that this is a change from the normal level of confusion or the normal conscious level of the patient. The final and fifth SIRS criteria for emergency department triage is a glucose or BM reading of greater than 7.7 millimoles per litre. Now this is a relatively normal glucose to have if you're a diabetic. So if you're a diabetic patient and your glucose is greater than 7.7, it doesn't trigger as one of the SIRS criteria for the purpose of sepsis screening. So the important things are temperature, respiratory rate, heart rate, acute confusion or reduced conscious level, and hyperglycemia. And remember that you need 2 of these SIRS criteria to progress further down the chart.
So if you don't have 2 of those criteria, then you can be quite confident moving over to the right-hand side of the chart that sepsis is not currently present. In that situation, you would treat the patient according to standard protocol, but within the emergency department setting, you must remember to review the patient prior to discharge home or prior to admission to the ward with their white cell count. And if their white cell count is less than 4 or greater than 12, you need to go back, see if they now have SIRS, and if so, reapply the screening and action tool. In terms of sensitivity and specificity, well, SIRS is part of the international consensus definitions criteria for the recognition of sepsis. So we have to assume, therefore, that SIRS is 100% sensitive for sepsis. But it's not very specific. If we can imagine someone who's broken their leg coming into an emergency department, the pain, the anxiety that will cause, possibly with a bit of blood loss as well, is very likely to cause their respiratory rate to be more than 20 and their heart rate to be more than 90. So just because a patient has SIRS does not mean that they necessarily have sepsis. This is the first step of the process.
So moving on to the second step of the process. So we've assessed our patient, we've looked at the opportunities when we can assess them, and we've found our patient to have 2 of the SIRS criteria. And moving on, the next question we should ask ourselves is, could this be due to an infection? So do we think these SIRS criteria are not due to the broken leg, which Ron was talking about, but they're due to an infection? For example, a pneumonia or a urinary tract infection. There are obviously many different sources of infection. Some of the most common ones we touched on previously. We're not going to cover all those sources of infection today, but they're going to be specific to your clinical environment.
And what we're not looking for is, for example, British Thoracic Society criteria for the diagnosis of pneumonia. Remember, sepsis is a time-critical condition, as it says at the top. So if a patient describes to you, well, I've had a purulent cough, I've been coughing up green phlegm, and I've been feeling steadily worse over the last few days, and you listen to their chest, or if you're not qualified to listen to their chest, someone has listened to your chest and told you that they're rattly, then we would be satisfied that that's sufficient clinical evidence that the patient has a pneumonia. And in that context, we would identify that the patient had sepsis. Of course, if you don't think there's an infection, then we revert back to the top right-hand part of the chart. Sepsis is not present now.
So if you do think there's an infection there, what next? So we've had a patient who is SIS positive. They've got 2 SIS criteria, and we think their SIS criteria are due to an infection. What we need to do now is a risk stratification.
So now we're going to move on to box 3 on the left-hand side of the screening and action tool. Is there a red flag present? Now, most of you won't have heard this term, red flag sepsis, and there's a good reason for that. That's because it's new. We're introducing it now across the NHS in order to accept and acknowledge that there are clinical areas that don't have access to laboratory results immediately. Those will be clinical areas outside hospital, and those will be in the emergency department, where, as we've said before, patients present having not had blood tests taken. Do we want to wait for an hour in order to initiate treatment for those patients? Well, clearly if they look quite stable, then it's very legitimate to wait for an hour to identify severe sepsis through the blood test. But if they look unwell, then it's not. Now, in some cases, the clinician or the nurse looking after the patient will have years of experience under his or her belt, and there is no substitute for clinical acumen, clinical gestalt, the end of the bed test, the sixth sense, whatever you choose to call it. If you've got years of experience under your belt and you know a patient's sick, then you will be able to make the judgment call as to whether to initiate therapy for severe sepsis, pending the blood results. But if not, we're going to look for the red flag criteria.
So the red flag criteria are derived from those traditionally used to diagnose severe sepsis and septic shock, and taken from the National Early Warning Score system. So the criteria we're saying that if you're positive, and you only need one of these, unlike SIRS where you need 2 criteria, are blood pressure. So anyone with a systolic blood pressure of less than 90 or a MAP of less than 65 is red flag positive. A lactate of greater than 2 millimoles per litre, and that may be taken from your VBG, it may be taken from your ABG, or it might be taken from a point of care testing of capillary blood. A heart rate of more than 130 beats per minute is a heart rate that we'd be concerned about, even in the setting of atrial fibrillation. A respiratory rate of greater than 25 per minute, and this is why it's really important that we record respiratory rate correctly. In the SIRS criteria, it's more than 20 beats per minute. A red flag criteria is a respiratory rate of more than 25 per minute. We're looking for oxygen saturations of less than 91%. And we're looking for patients which respond only to voice or pain or are completely unresponsive. The final thing on our red flag list is the presence of a purpuric rash. So that's the rash we traditionally associate with meningitis. Now, a majority of the patients we assess for red flag sepsis will not have red flag sepsis. They will have just sepsis.
So in the situation where we don't have a red flag, then we can assume, because we've identified 2 SIRS criteria, we think the patient's got an infection, that sepsis is present. In that situation, there is opportunity for clinical judgment. We need to determine whether or not, according to your local protocol, you're going to implement a sepsis care pathway such as the Sepsis 6. We certainly need to inform the nurse or the doctor in charge according to your status and profession. We need to ensure that observations are undertaken a minimum of hourly, if not more frequently, and that there are reassessments. Remember that patients with sepsis can deteriorate. The natural course of the illness is that patients commence with an uncomplicated infection, then develop some SIS criteria and have uncomplicated sepsis, and then progress through to severe sepsis, firstly with one organ dysfunction, and then perhaps to multi-organ dysfunction and septic shock, the most severe end of the spectrum. So we need to reassess. We need to remember to look back at the bloods, because the patient might have severe sepsis that is only identifiable once the laboratory tests come back. For example, their creatinine might be greater than 177. We do also need to remember that not every patient who we initially think has sepsis turns out to have sepsis. So we need to think about those sepsis mimics. Might they have an acute severe asthma that gives them respiratory distress? Because we switched on to sepsis, we might have suspected it and started the pathway, but we need to be open to other sources. Back to the red flags for a moment. With those red flag criteria, I'd just like to highlight that there are 3 that are not within the existing severe sepsis recognition criteria. These are the ones that Tim mentioned are drawn from the NEWS score. They're each associated independently with a score of 3 on NEWS, and they're the heart rate of more than 130, the respiratory rate of more than 25, which I think is breaths per minute rather than beats per minute, Tim, and oxygen saturations of less than 91%.
Thank you, Ron. I just wanted to talk about sepsis mimics. Now, Ron mentioned asthma as a sepsis mimic. Another sepsis mimic might be pancreatitis. It's also important to remember that a patient can have both asthma and sepsis and may deteriorate so that they have severe sepsis or sepsis shock. Patients' asthma may have been triggered by a lower respiratory tract infection, and they may need the Sepsis 6 as well as their asthma treatment. So this is where clinical acumen comes into play, and making the decision that a patient does not have sepsis but is SIRS positive is a decision which should be made by a senior clinician. So going back to our red flag criteria, what if they are present? What are we going to do next?
So if we have a red flag criterion, for these groups of patients where we don't yet have their laboratory tests back, we've accepted that this patient has 2 SIRS criteria, a source of infection. They have sepsis. We've now determined that they have a red flag criterion, whether that be from the NEWS score or whether that be one of the original surviving sepsis campaign criteria. Nonetheless, we've identified this as a patient with sepsis who's ill. This is a time-critical condition. We need to act immediately. And for example, for the most severe end of the spectrum, those patients with septic shock who might be hypotensive or have a high lactate, if we don't act, it has dire consequences. For every hour we delay in initiating antibiotic therapy, for example, the risk of death increases by 8%. So it's legitimate to assume in this group that severe sepsis is present. And we're going to initiate therapy with the Sepsis 6.
So the Sepsis 6 is covered in detail in another video cast, and I'd strongly advise you to go and have a listen to that. The Sepsis 6 consists of 6 interventions which, when delivered together within 1 hour, we know saves lives. The 6 interventions, which should be delivered in a very maximum of 1 hour, but ideally as soon as possible, are delivering high flow oxygen. Some caution might be given in patients with COPD or patients with known type 2 respiratory failure, but a majority of patients with severe sepsis or septic shock or red flag sepsis are going to benefit from high flow oxygen. The second step is to take blood cultures and consider source control. At this point, some clinical acumen is required. What is the likely source of this patient's sepsis? Is it urine, in which case we're going to take both blood cultures and a urinary culture. Immediately after taking blood cultures, we recommend delivering a broad spectrum intravenous antibiotic. We're not going to recommend which antibiotic to deliver. That's going to depend on your local policy and guidance and what you think the source of this sepsis may be. We're recommending that all trusts in the UK have an antibiotic policy which covers sepsis of unknown source. And this means that we are not paralysed by inaction, so we know that we're going to deliver an antibiotic, and then we can refine this choice at a later date when we've got more idea of where this patient's sepsis is coming from. The fourth stage is delivering intravenous fluid resuscitation, and we're recommended fluid boluses, generous, judicious fluid boluses up to a maximum of 30 mils per kilogram. This is going to be a significant amount of fluid and more than we've traditionally administered to unwell patients. In someone like me, a 90 kilogram male, it's going to be almost 3 litres of fluid before I consider adding a vasopressor or an inotrope. The fifth stage is to check haemoglobin and to perform serial lactates. We know that lactate clearance gives us a really good idea of the patient's prognosis. So it's important that not only do we get our initial lactate, which is one of our red flag criteria, but also that we take a lactate after a minimum of an hour to see how we're getting on. The final part of the Sepsis 6 is hourly urine output measurement, and it's really important that fluid balance charts is taken. This might not mean a catheter straight away, but for a majority of unwell patients, especially patients responding not particularly well to the initial Sepsis 6, this is going to involve placing a urinary catheter. Have you got anything you want to add to that, Ron?
No, absolutely. I think that's complete, Tim. We've shown previously in our own work, and it's been covered elsewhere, that the Sepsis 6 significantly improves the likelihood of survival. And this is something that a junior nurse working in collaboration with a junior doctor can achieve. The record, if you like to call it that, in my hospital for the Sepsis 6 is 6 minutes. It can be done very quickly, and it is life-saving. Most hospitals, we know that about 2/3 of hospitals in England use the Sepsis 6 and have clinical pathways associated. So if you have a paper or electronic tool that will record the actions, then you must use that. But if not, then just document the Sepsis 6 in the notes. What time they were delivered, what time each component was delivered, who delivered them, and what the calling criteria are. What you want the nursing staff, if you're a doctor, and what you want your colleagues to do if you're a member of the nursing staff, if the patient doesn't get better or if they subsequently deteriorate. When should they call a doctor back? So record the actions and communicate. These patients, if the patient has severe sepsis, their risk of death in England is 35%. Patients with septic shock have a 50-50% survival rate. I would suggest, and I say this as a consultant who's going to be the one on the other end of the phone, that the consultant must be informed as soon as you have a patient with red flag sepsis. I would say that's absolutely essential. These are the sickest patients in the hospital, other than perhaps those who've suffered multiple blunt injury and trauma, or penetrating trauma, or those with a ruptured abdominal aortic aneurysm. These are an extremely unwell set of patients. They deserve the most senior clinician and the most senior nurse available looking after them as quickly as possible.
So we've talked about the Sepsis 6, and just to touch on that just very quickly again, it needs to be delivered within an hour. That's not prescribing it within an hour, that's ensuring that it's delivered within an hour. So that's giving the patient the oxygen yourself, ensuring the antibiotics are in that patient's vein, and ensuring that fluid resuscitation is being delivered. Not just the first 500 ml, but every bag after that to deliver that first 30 mils per kilogram fluid bolus. So we need to deliver the Sepsis 6 within an hour. That's lots of time. We want it within an hour every single time, but as quickly as possible. We're going to communicate with a senior clinician, and that's going to vary depending on your clinical environment and your clinical background. Finally, there's some other stuff that we need to do. We need to take a full set of bloods, and that's going to include your full blood count, your urea and electrolytes, your LFTs, and a clotting profile. And that's so that we can diagnose these patients as either severe sepsis or septic shock. It also means that we've got a baseline set of bloods by which we can plan future care, and we can see how well our care is performing. Once a patient has red flag sepsis, we're advising that it should take observations every 30 minutes. As Ron said, these patients are critically unwell. They're some of the sickest patients in the hospital. We need to keep a close eye on how they're doing. The lactate should be repeated within 2 hours. Ideally, it should occur more frequently than that, but 2 hours is the maximum that we're recommending. Lactate clearance gives us a really good idea of that patient's prognosis and tells us how well they've responded to the Sepsis 6. We need to identify patients whose lactate continues to rise or does not clear with the Sepsis 6 so we can get additional teams involved. We're also recommending that you should be performing a chest x-ray and urinalysis. If it's clear that a patient has a CNS source of infection, you might think that these are unnecessary. Some patients will present with undifferentiated sepsis, in which case we need to find that source, and a chest x-ray and urinalysis are mandatory. The final thing to consider is source control. If this patient's infection is due to an abscess, they need surgical intervention. This isn't going to respond to antibiotics alone. So we need to think about where that infection is and what we can do about it.
So, we've gone through the screening and action tool. We've talked about red flag sepsis. This is a new concept. We've talked about a time-critical condition that is sepsis. We've talked about the sort of patients in whom we should apply a sepsis screening and action tool, and remember that there will be different versions of these tools depending on your clinical area, but they'll all be compatible and they will look visually similar and they'll all share similar criteria. So what do we do when we encounter a patient with sepsis? First, we look for the SIS criteria. We need 2. If they have SIS, then we look for a source of infection. If we think they might have a clinical evidence of infection, then they have sepsis. We then look for red flag sepsis, and we've talked about this new concept, this concept whereby we combine the parameters scoring a score of 3 on the news score and the traditional severe sepsis criteria that have arisen from international consensus definitions. We've understood that if a patient doesn't have a red flag criterion, that we should still consider whether they might deteriorate to red flag sepsis or deteriorate to severe sepsis or septic shock. So we don't take our eye off the ball. These patients still have sepsis as a cohort. They still have a 1 in 10 risk of death. So we need to make sure that they're regularly reviewed and they're recalling criteria. And it might be that in your hospital that the sepsis pathway recommends intervention in patients just like this with uncomplicated sepsis. If they do have red flag sepsis, we know that we've got to act quickly. We know that we've got to deliver the sepsis 6. We've got to escalate, we've got to communicate with our seniors. We've got to make sure that the senior most person who is able to look after the patient is doing so. So that brings us to the end of this video cast. Please take time to listen to and to look at some of the others, particularly that concerning the Sepsis 6.
Okay, so we've reached the end of our video cast now. We hope that you've enjoyed it. We hope that you found it useful. What we'd really like is some feedback. So please email us at info@sepsistrust.org. If it's positive, great. If it's negative, great. Let us know how to make these better. Let us know how to improve sepsis care in the United Kingdom. Thank you very much for your time today.